Well, hello, everyone. Can you believe it? Our second episode in the year 2021. Great to be with you out there in SADS Facebook Live land. I'm Mike Ackerman, if you don't know, genetic cardiologist at Mayo Clinic and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic. I'm coming to you on behalf of the SADS Foundation, the Sudden Arrhythmia Death Syndrome Foundation. I have the privilege of serving as its president these last many years. Alice, Laura, our CEO, and our entire staff team, Aaron and Marcia and Jan and others, thanks so much for choosing to spend your 40 minutes with us live, or if you're going to be watching this on recording later. So it's great to have you, and I'm looking forward to seeing who's joining live and some good Facebook Live friends. Can you believe it? It's episode 45. We started the new year together on January 1. How are your resolutions coming? Erin, I think, is trying to cook in French for her month activity. Some of you are trying to lose weight. I hope you weigh lighter 1 week later than you did on January 1st. I do. So I weigh a little bit lighter, not quite a pound. Some of you thought you would reach out to friends and make some contacts and remind and regenerate old friendships. So whatever your resolution was, don't try, do. I tell my kids, trying is easy, doing is what matters. So don't try, do, and just do it. You can do it. So stay fast. If you broke your resolution already, start tomorrow. Start now. Just be disciplined. Obviously, we have had an incredible week, haven't we? So 2 days ago was kind of a big day in America, and some of you may have questions about that. I think the day speaks for itself. America is still one of the best countries, from my standpoint, the best country in the world. It was on January 5th. It still will be on January 6th, and it is today. So our republic is strong, and we will leave it at that, because it's your questions about your genetic heart diseases that matter most to me right now. And so I see Brianna and Amy, Dana, Stephanie. Stephanie, that might, no, yeah, I recognize Stephanie. Hello. And Melissa. Melissa, we interviewed Melissa. She joined us. And so it's great to have you back, Melissa, or Erica from Germany, and Carol. And I know there's many others. So all of you, welcome back. We are on question and answer time, but reminder, COVID-19 pandemic, COVID-19, meaning it started in 2019, December, was there all of 2020, and it has not gone away. Mask up, just do it. The anti-maskers out there are crazy. The masks work. Wash up, do it. I wash my hands. My hands are so dry, it's incredible. Do it. It works. Some social distancing. We can have an argument about kids being back in school. I think they need to be. I think the devastation of kids' schools being closed and this online learning continuously and for as long is going to do long-term damage overall. So I am a pro return to school ASP person. However you're choosing to do it, be very aware of how is your child thriving. Are you thriving? And the vaccine, that we ended the year, Operation Warp Speed delivered. Yay. We have the vaccines, 2 in the United States approved. I got mine right there 2 days ago. And so we started our program at Mayo Clinic on December 17th, and my number came up some 20 days after that. And so, but we're not going to talk about COVID anymore, because hopefully, I'm waiting for final confirmation, Dr. Stacy Rizza is going to be back. She was with us in July, 6 months ago. So 6 months later, I'm hoping we're going to hear and answer your questions about the state of COVID-19. What's this business about this new strain and its infectivity? How is the vaccine and vaccines working anything and everything that of COVID-19. So that's it about the COVID-19 update. Then we have a great program in 2 weeks, and in 3 weeks, mark it on your calendar. My boss, our CEO, Alice, and her team, Aaron and Marcia and Jan, I'm going to be interviewing them, having a conversation about the state of SADS. How is our foundation? What are we about? What's our vision? What are we doing well? What do we want to do better? And get you more familiar with the behind the scenes workings of this organization, because you are this organization. And so now start posting your questions, because I'm going to take them for the next 35 minutes from top to bottom. We will go rapid fire. You guys, I love this. I hope you like these, because you guys have created for me a lot of new work. Many times your questions have stimulated a new question that I pose to our research team that they're busy working on to try to get a good answer. I'll do my best to give you truth. I will only tell you what I know and as accurately as I know it. Hopefully what I know is correct. And if I don't know, I will try to find out the answer. And if we don't know, meaning our scientific community that's trying to get smarter on behalf of your specific genetic heart disease, you can bet that I will start reaching out through the network throughout the world to get your question answered. Because if you have the question, it's probably a really good one and it deserves to be answered. And if the answer is not there, it probably deserves for us to figure the answer out. Well, hello, everybody. I'm seeing the greetings. Now I'm going to scroll down and see who gets the first question. Carrie just giving a thing. So that's interesting, Carrie, about LQT2 and seizure misdiagnosis and checking things. So we just had one of those this week. This whole story of seizures and long QT syndrome. So maybe I'll take a moment there on that one. Long QT syndrome, if it ever explodes and trips up into the long QT danger rhythm, you will always know it because you will always show it in one of three ways. You will either faint and then 10 seconds later wake back up because the rhythm rebooted all by itself. Or you will faint 30 seconds, 45 seconds, 60 seconds. The rhythm is still in long QT badness, poor SADS. You will then have fainted 50 seconds ago and then be showing a full-blown generalized head-to-toe seizure. That's why sometimes if that's what the person was observed doing, they get quickly called seizures, potentially diagnosed as epileptics, epilepsy, and so forth. Now, but the seizure stops, the person wakes back up because even 60 seconds later, the computer, the heart, rebooted and went back into normal sinus rhythm. Tragically, if you're at 90 seconds, 120 seconds, 5 minutes, and it hasn't rebooted, you fainted, you collapse, and now you're in sudden cardiac arrest and heading towards sudden cardiac death. Thankfully, that's the least expression, the least common expression of the long QT explosion. So the seizure part, more often, we published this several years ago, that more often than not, if you were called seizure, you would end up being LQT2 rather than LQT1, which raised the question, is it possible that sometimes, perhaps, if you have long QT2, you're just more vulnerable to low blood perfusion secondary seizures? It also raised the possibility, after it was discovered, that the long QT2 gene, KCNH2, lives in the brain, expresses the same potassium channel in the brain, especially the hippocampus of the brain, such that maybe some patients with long QT2, when they're having their seizure, are actually having a true brain seizure while their long QT2 heart is normal sinus rhythm. So both could potentially coexist in a given patient. And that's why it's really important for the doctor. And you're with Carrie, a great doctor. Say hello to him. Good friend of mine, Dr. Brule. You're in good hands. So let's see. Yeah, Ireland. I saw that about how high COVID is in Ireland right now, and just endure, stay corona free. You guys are doing a great job. The number of families who now we're a year later are still corona free. Thankfully, my family of 4 children, my wife, our granddaughter, we're still all corona free. Do your best to the same. Sophie from the Netherlands. And I think we might have a great crowd from the Netherlands and Arthur Wilda's program joining us next Friday, if indeed we have our COVID-19 update. And Stephanie's asking that her daughter's, I think QTC, it says ACT, but I'm pretty sure, has gone from 480 to 500. Is that concerning? A great question. In general, a person's QTC in the morning, which is when we get the electrocardiogram for your annual evaluation or your periodic evaluation, will fluctuate. It'll have its swing. That swing is probably a plus minus 30 millisecond swing. So somebody who's 480 on year 1 and 490 on year 2 and 460 on year 3, no big deal. What becomes the big deal is how often is that number. So we have a paper under review that talks about Qtc persistence, meaning if every one of your yearly ECGs tracks with a QTC as a median above 490, much higher risk than the person whose QTC kind of bounces all over the place, 490, 460, 470. So somebody whose QTC is persistently on their annual ECG above 490 is at much greater risk. For somebody who is 480 one year, 500 the next year, 480 1 week, not as big of a deal. We know that if your QTC is ever at rest on any of your annual evaluations above 520, that's probably a better line in the sand for risk forecast than even 500. So the 500 might have been a little bit raising the red flag a little too soon. So bottom line, Stephanie, not as big of a deal to bounce around. Brianna is next. If you have a family member that carries the family's pathogenic gene and they refuse to get any care, what can I do to make them understand? Well, knowing you, Brianna, you've done a great job. And I think that's all we can ask our families to do is inform. SADS Foundation has resources, and often your genetic counselor will help you with a letter that you can send so that it's explained to them. You can lead them to the water. You can't make them drink, but then your hands are washed and you will never have to feel guilty should tragedy strike. We've had a couple of occasions in 20 years now where tragedy has struck when the immediate family knew of the result and chose not to inform. And then 5 years later, cousins over here, down there, then died tragically. So knowledge was there to be had. Had it got disseminated and acted upon, diagnosis could have been made, treatments could have been started, tragedy would not have happened. Because when we have diagnosed you correctly and treated you correctly, tragedies almost never happen. So you've done your part. That's all you can do. And so we'll leave it at that. Lisa's, is resting heart rate important for those with Brugada syndrome? My heart rate is often slightly below 60. Great question. No concern at all. Your resting heart rate has zero risk in Brugada syndrome. The 3 most important risk factors in Brugada syndrome, Lisa, is has it ever struck in you yet? Meaning a worrisome faint and Brugada syndrome almost always equals an implantable defibrillator. If you've never fainted, then some of the potential risk forecast values are staring at your electrocardiogram and seeing how chewed up or nibbled up is the QRS, something called QRS fragmentation. And then the other risk factor that makes you higher risk than not is your type 1 Brugada ECG pattern, the thumbprint, fingerprint of Brugada syndrome, is it present every time you get an ECG, or does it come and go? And those where the pattern comes and goes are at much lower risk than those where the pattern is there no matter which year, what day you got your ECG. Your heart rate, no risk. Great question. Kristen's, your mom was diagnosed with Brugada, waiting your genetic test results. They came back positive. Can you talk about the next steps I should follow? Great question. So right now, if you've been diagnosed with Brugada syndrome, and that diagnosis is correct, the current genetic test explains about 20% of Brugada syndrome. In other words, most Brugada syndrome is going to be negative genetic test Brugada syndrome. If your family is among the 20% where you have the test result and it's positive, then it's easy. In other words, you will then prosecute the family members for the presence or absence of that genetic marker, your mom's genetic marker. Those who do not have it and have a normal ECG are dismissed. Those who do have the marker then get put into the close scrutiny box to look at, what does your ECG show? Can I see it easily? Do I have to move the leads up the chest to see it? And then a preventative program is put in place. Drugs to avoid, www.brugadadrugs.org. Some vices to stop. Alcohol to drunk, no more. Marijuana, no more. Cocaine, never. So we take some things away, potentially, if you have Brugada. So for your next step is, if mom's positive, you get tested. If you're positive, your children get tested. If you're negative and your ECG is normal, you're done. Your children do not need to be tested. If your mom's genetic test is negative, but she really has Brugada syndrome, then what we would do is just your mom's first-degree relatives, her siblings and her children, you would get the Brugada ECG, 3 ECGs recorded with the leads in the standard position for the first ECG, moved up 1 rib cage for the second ECG, moved up 1 more for the third. If the ECGs look normal, we dismiss you. If the ECGs look Brugada consistent, then we put in the preventative measures. I love that one, Kristen. Michelle is asking, are children with borderline long QT likely ever to be able to come off of their medication? Bisoprolol is the beta blocker that they're on. So maybe you're Canada. Can you tell me if I'm right? And the 484.49, 495. I like the question because just this week, it took, I think, 3 days into the new year before we removed another diagnosis of overdiagnosed long QT syndrome. So the first question I would have to force myself to convince is, do I really think your children even have long QT syndrome? If yes, the borderline QT interval helps put us in a very low risk category. If no, meaning the genetic test is negative, there's no story, and all that I have is this Holter thing, then I would be sort of asking myself, do I even want to call your child long QT syndrome? So I do have patients where they have been borderline, where we have removed their beta blocker. I even have patients who I know have long QT syndrome, but I think their risk is so low that we have started to explore the idea of what we call intentional non-therapy, preventative measures only, drugs to avoid, and so forth and so on. So I think it really depends on, does your doctor really think that your child has long QT syndrome? Carrie's wondering about COVID vaccines, and yeah, I'll answer it. Any concerns receiving the vaccine in the setting of LQT5? 0. Everybody who is eligible without contraindication should get the vaccine. Everybody. I did. That includes my wife, who I'm trying to talk into it. She's not quite so sure. So I get it. I get the thoughts out there about, should I get the vaccine? Maybe I don't want to. Maybe I'll take my chances because it's pretty benign, the virus. If I'm young, if I'm not obese, if I don't have diabetes and hypertension, and since my wife doesn't have any of those and she's still young, she thinks, then maybe she will just go without the vaccine. I disagree. I'm working on her. Work on you guys as well. So yes, get the vaccine. Your long QT syndrome, your Brugada syndrome, your Cpvt, your LQT5, none of those are contraindications to getting the vaccine. The vaccine is safe. It is QT safe, unlike one of those treatments. Remember, some of those 2 medications that were used right at the beginning in February and March of last year are QT dangerous if you have long QT syndrome. The vaccine is not. It is not dangerous if you have long QT. Get your vaccine. Nicole, LQT2. Oh, I just lost my place. Where did that go? I'm going to stay in order so nobody can say that I was picking favorites. Nicole, LQT2, type 2, second most common. No meds, only a defibrillator. Do I think that's okay, or should we be on medication as well? Ooh, that's a great question. We published our paper on that. Maybe Alice and team can get it to you. It's called ICD monotherapy in long QT syndrome, where we looked at our 2,000 or so long QT syndrome patients seen here at Mayo Clinic, taken care of here, and examined the subset who chose defibrillator-only therapy. That's a very small subset. So you're in small company. I would say less than, well, overall, we don't need defibrillators in most long QT patients. We've talked about that. Remember, if you do have a defibrillator, the new news is that Apple 12 phone held over your ICD, the magnet in the phone can turn off or inactivate your ICD shock function. So do not have your phone, the Apple 12 or whatever it's called, the iOS 12, do not have that over your generator. So first, most don't need a defibrillator. Most shouldn't get a defibrillator. In our entire program, less than 20% of all of my patients have a defibrillator. 80% do not. Of all of my patients, probably, I think it was kind of like 1%, have a defibrillator and nothing else. Is it okay? It could be for that 1%, as long as we chose that for a good reason. What might be a good reason? Might be a good reason is I need a device, but I'm hating my beta blocker. I just hate it. Can't do it. You could have chosen your defibrillator carefully. In general, if somebody has long QT with a defibrillator, they are also on one or more other long QT medication. But I have patients, not very many, who have chosen defibrillator only. And for them, it may be reasonable. Carrie's wondering about her son who's turned blue after convulsions for 2 and 2.5 minutes. Not sure if it's the heart. Probably not the heart. Your team will be looking carefully at that. Sometimes if the brain doctors can't convince themselves and the heart doctors can't convince themselves, we do slip in what's called a loop recorder, an ILR, an implanted loop recorder, so that if there's the next convulsion, we would know what we call rhythm spell correlation. So we could figure out whether the convulsion had anything to do with what the heart was doing. So unlikely to be the heart, but should be carefully looked at. Yeah, so Michelle is just following up about the 6-year-olds and the twins. And I would just say, I think with a negative genetic test, remember, a negative genetic test in long QT syndrome rules out 80% of the disease all by itself. So if I'm going to call somebody long QT syndrome in the setting of a negative genetic test, the data better be really good. And if the data is not really evidence, is not really convincing, I would not necessarily treat somebody with beta blocker. And so I'm sure careful attention is being given. I think if the diagnosis is based on the Holter, then I'd raise a little bit of a yellow flag. In other words, if it's only the Holter that's causing the designation to be given, pretty weak. We published several years ago that you relying on the QTC and how it varies during the Holter was one of the reasons for overdiagnosed long QT syndrome. Danny's asking a couple of periods of extreme stress over the last 15 years, both periods stop breathing in your sleep. First one about 15 years ago, gasping for breath. Lately, I've woken up unable to find my airway as my throat is closed. Is this related to my long QT or other? Apology for the long post. That's okay. I accept it. That would be really unusual for long QT syndrome. Long QT almost never does that. So I think one should be looking at things. I don't know your age, your body size. I think we should be thinking about possibility of sleep apnea comes to mind. You would want to know what your long QT is itself. What's the risk? In men, it could be a long QT dud if you're an adult. If women, something of concern. But just that story would be one that I would say in 20 years and 2,000 long QT patients, I've never heard. So everything's possible. But I think that's a doubtful one. Thanks. And where are we next? Long QT patients in COVID. Oh, great question about having COVID and your son just tested positive. If your son's otherwise healthy, he's going to clear the COVID just fine, just like my 24-year-old son would. So the long QT itself is not a risk factor for whether COVID-19, the viral infection, will be serious or not. The only concern, and hopefully this won't be happening, is if somebody were to choose to treat your son's COVID-19 with either hydroxychloroquine or azithromycin. Both of these medicines are on the QT drug hit list, www.credible.meds.org. Both of these drugs are QT dangerous in somebody with long QT syndrome. So nobody should prescribe your son those medications. Yeah, Carrie's wanting Dr. Brule to come back. I'm glad your daughter loves him. I do too. And we'll see. We'll take note of that and have a return. Jennifer's wondering if there's any genetic links between scoliosis and arrhythmia disorders. No, there's no link. The only one, sometimes I suppose in the rare genetic heart condition of Timothy syndrome, there can be scoliosis. That's rare. Anderson-Towel syndrome, which is another one we hardly ever talk about. There can be scoliosis in that. But standard long QT, standard Brugada, standard Cpvt, standard ARVC, scoliosis, no. Having said that, scoliosis is far more common than any of these conditions. So if you take long QT syndrome, 1 in 2,000 people, scoliosis, maybe 5 to 10% of adolescent females, you're bound to have 5 to 10% of my long QT patients are going to have scoliosis. So but they're not linked or caused from each other. Erica is wondering if there's any research relation between a SADS condition, those that I mentioned, and a long word, Panayotopolis syndrome, as it shows cardiac symptoms while having seizures, including SUDEP. No, I don't know that syndrome, so I'd have to do my own digging. But since I don't know that syndrome, it obviously can't be connected to long QT, Brugada, Cpvt, because I ought to have known that syndrome. So I don't think so, but that's interesting. I might have a little weekend reading to do. Jesse's wondering, side effects when you get the vaccine in case you have Cpvt and taking propranolol and flecainide? No side effects. I got mine. Only side effect was a little. Some people said a lot of pain, little pain in my arm. I would say scale of 1 to 10, a 2. So no problem and no reason to worry about a side effect. Um, I need to know who you are because I don't know that the spelling of your name or the language. But you're asking, can you tell me if iodine can affect the QT? You took 350 milligram every day. I doubt it. Iodine has not been published, to my knowledge, as a QT prolonging agent. I've never heard that, so I think the likelihood is very low. Natalie is asking about LQT2 patient increased palpitations, PVCs, premature ventricular contractions, or PVCs. Those are skip beats, extra beats, premature beats, however your doctor has conveyed it to you. That's what those are for a heart rate under 40 after childbirth. Would the chance of an event increase? So great question. First, LQT2 pregnancy, no difference in risk. So pregnancy is not a risk factor for a woman with long QT syndrome. Not. Where the risk increases is not during pregnancy, not during labor, not during delivery, but in the 6 months after your baby is born, the postpartum period. And that risk that is higher is almost exclusively confined to women with LQT type 2. So we almost never see an increased risk in our LQT1 moms. So we do, like I did with my LQT2 mom from yesterday. She's 25 weeks pregnant. This is her third baby, beautiful daughter. I'm sure she'll be beautiful, will be born in April. We outlined the plan with the obstetrician. Pregnancy, let's not be worried. I do not call you moms with long QT syndrome high-risk moms. I don't like that. I don't think it's necessary. I don't call your babies high-risk babies and route you to the high-risk maternal fetal medicine clinic. I know some colleagues throughout the world do that. I respectfully disagree. I've had no need of that designation for 20 years now. Now, what we do is we say, okay, after your baby's born, we are entering into a higher risk window of time, not a spooky risk window, a higher one. So let's just be on our A game. Do we like the amount of medicine you're on? Can we do some things to make sure we're trying to sleep well and not get startled? Yeah, nice try with some of the baby. But I would say long QT2 moms who out there, you might be afraid, given what you've heard about the postpartum period being dangerous. I want to try to encourage you that scenario is for those who that's how their long QT got discovered and how the first symptom happened. This is not the storyline of long QT2 moms who have been diagnosed and treated and are on good treatment. The postpartum period in that setting is almost always completely safe. So that's really, I'll give you some Friday good news. Oh, wow, we are on good. I always get dizzy and I feel like I'm going to fall when I get dizzy. So if that's the case, dizziness is basically never a symptom of these genetic heart conditions. Dizziness can be coexist for non-long QT reasons like a vasovagal tendency or orthostatic hypotension, meaning I get up quickly, my blood pressure drops a bit, I get dizzy and lightheaded and woozy. So depending on the situation, some of the simple antidotes are, is your fluid tank, your intravascular volume, filled to the brim? Are you drinking 80 ounces of non-caffeinated beverage a day, water, Gatorade, etc.? If not, you should be. That can help your dizzies a lot. Compression stockings, if we needed to, can help. Exercising can help. Weightlifting, doing squats can help counter the tendency towards dizzies. The Brugada, Allison, and how would I treat a patient with Brugada and Drave? Easy. I treat the Brugada if I need to. So if it's asymptomatic Brugada, low risk, I just do the Brugada preventative measures. If it's Drave, and then I deal with the Drave part, because most of the Drave syndrome therapies are not Brugada aggravating. So that's a pretty easy one overall. with CPVT, Carrie's asking, what causes long QT intervals on the monitor? Is it medication or related to the CPVT? I highly doubt that there's QT prolongation in CPVT. CPVT patients basically always have a normal QT interval at rest, normal QT interval on Holter, normal QT interval on stress testing. So the first explanation would be that the measurement during the monitor from the monitor is inaccurate. Rajshri, your daughter has calmodulin mutation. Part of the research, I want to know if COVID vaccine is safe for her. Know how you can see me. You can see me easily right now. No, I'd be delighted to see you. All of you know that Mayo Clinic is open for business, both on campus and telemedicine, video consult, and you are able to call Erlene. Many of you know her on a first name basis. She is command and control for Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic, 507-284-0101. Now, calmodulin. Calmodulin is one of the newest rare forms of either long QT or CPVT, depending on how the calmodulin mutation is expressing itself. And the vaccine is safe, absolutely. Now, if your daughter is under 16, right now, she's not eligible for the vaccine because right now, in the United States, and I'm pretty sure throughout the world, the Pfizer vaccine and the Moderna vaccine is approved for 16 years old and older. Carrie's wondering about medications for her son with CPVT to avoid or not be prescribed. That's kind of the good news, beauty of CPVT is unlike long QT syndrome, which has its hit list of drugs to avoid, long list, www.crediblemeds.org, and Brugada syndrome, which has its hit list to avoid, which is almost never an issue, www.brugadadrugs.org. CPVT has no hit list. So there's almost no medications that are CPVT agitating. So I don't really tell my patients that they have to avoid any medication for their CPVT. And we've come towards the end. I didn't quite get through all of them. I tried. We'll maybe park these for the next question and answer session. I think you can reach out to Alice and Aaron and Marcia and let them know how often, and I think this is a good question, how often would you like your SADS Facebook Live session to be this, the question and answer segment versus the interviews and dialogues? Would you like it once a month, once every 2 months, every other week? Let us know, and we'll cater to your needs because we're here for you. This program is about you. So I'll take one last and see if I can take one of the last ones that snuck on in here. Gnats. I'll take gnats. What electrolyte drinks do we need to have to maintain electrolyte levels for long QT subtype 3? Great question, Nat. Doesn't matter what subtype. Whether you're LQT 1, 2, or 3, in general, if you are well, you don't have to be doing any electrolyte drink. The only time we have to think about electrolyte replenishment is if I'm an athlete and I'm dehydrating, needing to replenish throughout my workout on 2-a-days outside in hot sun, or I'm sick and under the weather with a GI bug and I'm actively losing electrolytes, diarrhea, vomiting. In that setting, then I should do it too, but I don't need to do it as importantly as somebody with long QT. But you with long QT type 1, 2, 3, anything, also Brugada, need to then say, am I staying replenished? And there, any of the electrolyte replacement drinks, Gatorade, Powerade, some of the vitamin electrolyte drinks are just good. And then you just gauge as your litmus, am I keeping fluids down? Are my lips moist? And so forth. And I almost never need a patient to need to go to the emergency department to get their potassium level checked because they think that they are getting behind on their fluid maintenance or resuscitation. So overall, I would say pretty easy. Well, we gave Nat the final question of the day. Do reach out to my boss, Alice, because I just do what she tells me to do, as to how often you would want the question and answer session. And as we wrap up this Friday, I want to just quick check my email to see if I have confirmation yet about next week. And no, but let's plan on that. It's going to be what I said with Dr. Stacy Rizza. Let's have a great weekend together. Resolution, you came off the wagon already, get back on. Don't wait till next year. Do it now. When it's your turn for the shot, get your shot. Can you see? I got mine. Go Sick 'em Bears. Remember, that's where my son is. And remember, last weekend, I started the new year off in a great way, as good as I can, with my wife and I were allowed our first babysitting experience of our granddaughter. So we went over to Madison and got to babysit for the afternoon while the kids went snowboarding. So we passed, and can't wait to get to do it again. So until next week, be well, stay corona free, put on the mask, wash the hands, and refuse